بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. First of all, I want to introduce myself. My name is Ahmed Zaid Al-Khalaf, fifth year dental student, Salman bin Abdulaziz University. Our presentation today presented by Dr. Barish Sadqizad. He is Assistant Professor, Tenure Track Director, USC Center for Biofilms, Diplomate, American Board of Oral and Maxillofacial Pathology, University of Southern California Outside School, Dentistry of USC, California, USA. The lecture title, What Every Dentist Should Know About Clinical Oral Pathology and Medicine. So most welcome, Dr. Barish.
Thank you very much. It's a pleasure to be here, and I just want to congratulate the dental students. I'm guessing you've done a wonderful job. It's an excellent program, very classy, very professional. So my hat's off to you if I had a hat on. All right, so what every dentist should know about oral pathology and medicine, with the subtitle, Approaches to Clinical Diagnosis. This talk is going to really focus heavily on clinical diagnosis of lesions that we would see clinically. So this is very applicable to anybody that sees patients, whether it's dentist, dental student, hygienist, etc. So the goals for the talk right now are first to discuss stages in evaluating an oral lesion. And then second, a process to develop a differential diagnosis based on the normal anatomy of the site. And then finally, procedures that can be done to refine the differential diagnosis and establish a more definitive diagnosis, and discussion of treatment of common oral lesions. All right, so let's get started. So the first thing, stages of evaluation of oral lesions. The first thing I want to talk about is recognition of tissue alteration. When you do an exam and you see something, an oral lesion, there is actually a process involved. And a lot of times we learn throughout our training that oral pathology is difficult, it's hard, and you have to memorize lots of different pictures, and if you don't know what the lesion looks like based on what it matches to the picture, you get confused, and that's not actually how a good diagnostician or clinician approaches diagnosis. So I'm going to really try to discuss a paradigm or a process today that can be readily used in the clinical setting. So the first thing you want to do is actually know something about the history of the condition and observation of lesion parameters. Anatomic location of a lesion is key. So the first thing you do is you obviously would look at a patient and you'd identify a lesion. You'd see something that may be abnormal as opposed to normal. So knowledge of the pathology has to be predicated on knowing the normal anatomy first. And everyone in here is already an expert on normal oral anatomy. So that's kind of an easy starting point for everyone. So anatomic location is important, and we generally have a saying that pathology usually arises from normal anatomy. Okay? And that's not always true, but for the most part that's true. That there has to be some normal anatomic structure, and then that structure is what gives rise to the pathology. Okay? So the location of a lesion when you observe it is actually very important for differential diagnosis and diagnosis. Second, the color of a lesion is very important. Okay? Color tells us a lot clinically about what a lesion could be. For example, when you see something that's red, what does that tell you? You usually think of something that's vascular, or blood, or inflammation, right? When you think of something that's brown, you think of pigmentation, melanin pigment, for example. When you think of something that's white, you think of keratosis, or increased epithelial layers, right? So the color of a lesion is actually very significant for differential diagnosis. And then size and growth pattern. How big is the lesion? And not just how big is it, but how big has it gotten over time? Sometimes when you see a patient clinically, you only have a snapshot. You only know if it's small or if it's large, and you're not sure how long it's grown, unless you can get a good history from the patient. If they can tell you, oh, this has doubled or tripled in size in 2 weeks, that's very helpful. So the size, but the actual growth pattern is very important. And then the shape and the borders. Lesions that are well-defined tend to be less harmful than lesions that are poorly defined or ill-defined. And you've heard some of these things before, but we'll go through this with examples and look at many, many examples. And then the texture or consistency on palpation. When you see a lesion and you touch it, what does it feel like? Does it feel soft? Does it feel rubbery firm? That tells you a lot. Does it feel hard, if it feels bony hard, for example, that tells you a lot of information. And all of these things will help you with differential diagnosis. So the goal here is to actually have a paradigm or a process, because you're always going to see things, everyone does, I do every day. I still see things, I don't know what it is, and I know every picture or lesion in the textbook, and I still see things that I don't know. And I don't freak out and say, oh, no, I don't know what it is, and you don't know what to do after that. There's a process, and as long as you follow this process, pathology and clinical diagnosis is actually very easy. So, no more A to Z and picture recognition. The goal isn't to memorize 1,000 lesions and know exactly what each picture of the textbook looks like and try to match that up to what you see with your patient. Trust me, we're just going to follow a process here, and the process takes care of itself. So, obviously the history of the present illness when you see a lesion is very important. When did the lesion come about? How long has it been there? Are there signs and symptoms? Is there pain associated with it, or swelling and things like that? If there's pain, what's the quantity of the pain? You know, on 0 to 10 scale. Is it a lot of pain? Is it very little pain? That's very important for differential diagnosis. And the quality of the pain is very important. Is it sharp? Is it dull? Is it constant? Is it throbbing? Is it intermittent? Is it worse at some time of the day versus other times of the day? All of those qualities are actually very important for differential diagnosis. And then obviously things like a history of trauma at the site of a lesion, or medications the patient may be on, may be very important for differential diagnosis. All right. So, oh. Yeah? All right. So, like I said, most pathology comes from normal anatomy at the site, and everyone here is pretty much an expert already in the anatomy. Whether it's gross anatomy or histologic anatomy, it's the same thing. Anatomy is anatomy. Okay? When you see it clinically, you're seeing it grossly, you're seeing it in real life. When you see it under a microscope, it's the same thing you see clinically, but you're just seeing it at a higher magnification or power. So the anatomy and histology plays a significant role, knowing the layers of the tissues and trying to figure out where a lesion comes from. Does it come from the epithelium or surface? Does it come from the connective tissue further down? Does it come from the muscle even deeper? Does it come from bone or periosteum, which is even deeper, for example? All of those are very important, where a lesion comes from. And you can see that usually clinically. You can tell with very high positive predictive value where in a layer of tissue and epithelium and subepithelial tissues and et cetera that a lesion comes from. So there's a language that we all need to speak at least to be able to describe lesions, and that's this slide. We talk about lesions as being cystic, which is basically an epithelial lined sac. You can have a fissure, which is a little cut, basically, in the epithelium, or mucosa, if we're talking about the oral cavity. You can have a macule, which is something flat. You can have a nodule, which is something raised, or a papule, which is kind of a small nodule, a polyp, which is a pedunculated lesion, a pustule, or a vesicle, or a wheal, an ulcer, and a plaque. So there's lots of ways to describe a lesion, but this is important because this is really the language of describing a lesion. And a lot of times, you know, a dental student will come to me and say, I saw this lesion in a patient. What do you think it could be? And if I don't have a picture, I need them to be able to explain it to me. And if any one of you have to explain to someone else what a lesion looked like, you'd want to use this terminology. It's a well-defined plaque that's non-wipeable, for example, or it's a wipeable plaque, or it's a nodule, okay, very firm, rubbery nodule, et cetera, et cetera. So this is a language that we speak with, and it gives you a lot of information. For example, something like a pustule is usually what we call an exudate, which would generally imply what? Bacterial infection, for example, right? If you think of pus, acne, something like that, versus a transudate, which is like a vesicle, which is usually not pus and may be associated with something like a viral infection. So just the nature of a transudate versus an exudate and being able to identify that may tell you actually what your differential diagnosis is. So very strong. So look at these two lesions, similar locations, but two very different lesions. Okay? The one on the left is a wipeable white plaque. The one on the right is a non-wipeable white plaque. Which of these will you be more concerned about? A white plaque that's wipeable or one that's non-wipeable? So in this case, the one that's non-wipeable is the one that I'd be more concerned about. Wipeable plaques are usually candidiasis or thrush, and non-wipeable, in this case, is actually leukoplakia or histologically dysplasia, precancerous lesion. Right? Two more lesions. Similar location. Ventrolateral tongue, near the base of the tongue. Both are ulcers. Which one of these would you be more concerned about? Think about it in your head. One is very well-defined ulceration, right? The one on the left. The one on the right is not so well-defined. It's not very clear exactly where the borders are. It's a little more complicated in character. It actually is a little more raised and has indurated or rolled borders. Okay? So the one I would be more concerned about is the one on the right. And the one on the left was just a traumatic ulcer that healed. And the one on the right, after biopsy, was squamous cell carcinoma, cancerous lesion. Okay? But if you look at the features, the morphology, the dermatoglyphics, the way it looks, whether it's well-defined, poorly defined, the borders, okay, the morphology tells you a lot, potentially, about the diagnosis or differential diagnosis. Okay. Two more lesions, similar anatomic site. Okay. The one on the left is smaller, relatively well-defined. The one on the right, larger, not so well-defined, rolled borders. It looks ugly. Okay? And if you can't describe it, at least you should know in your head that one of these looks not so bad and the other looks much worse or ugly. So the one I would be more concerned about would be the one on the right. And the one on the left was just a traumatic ulcer that healed within a couple of weeks. And the one on the right is squamous cell carcinoma, cancer of the lip. Okay. Two more lesions, similar location. All right. Which of these would you be more concerned about? The one on the left or the one on the right? And why? Okay. I look at them and they look relatively similar, two kind of nodules, right, on the palate, but one is larger than the other. And just on size alone, I would be more concerned about the one on the left versus the one on the right. So I'm trying to reinforce these concepts of size, shape, growth pattern, color, texture, okay? These are very important for differential diagnosis, as you can see. The one on the left was a salivary gland tumor on biopsy, and the one on the right was an irritation fibroma on biopsy. Okay? You would almost know that even without biopsy. Biopsy almost proves what you already know and think. Biopsy isn't, oh, I don't know what it is, so let me just take a biopsy. Some things you don't need to biopsy. If you already know what it might be or have a good differential diagnosis, then you don't need to biopsy every case. Some cases you can just leave alone and let it heal because you know that it's not potentially cancerous, et cetera, et cetera. Okay. Two more lesions. Gingival tissue, both pigmented, okay? Very dark, kind of brownish, purplish pigmentation. Which of these two in your head would you be more concerned about if you saw these patients? The one on the left or the one on the right? Left? Right? Yeah. I like it. You guys are with me. That's good. All right. So why the one on the right? Yeah, irregular borders, right? Both are pigmented lesions, but the one on the left is very uniform, diffuse, bilateral, nice pigmentation, which you can see with racial or ethnic populations. You can see this in practically anyone, okay? The one on the right is also pigmentation, kind of the same color, but is poorly defined borders, okay? And it's not actually a very uniform pigmentation. If you look at the colors on the one on the right, there are a lot of different colors in there. There's pink, there's brown, there's purple, there's black, there's blue, okay? The one on the left is just melanosis or melanin pigmentation, racial pigmentation. The one on the right is melanoma on biopsy, okay? And you can tell that just by looking at it clinically. Okay, I've seen all these cases, and they're biopsy-proven cases. I didn't do a biopsy on the left. That never changed. It's an African-American patient, very common finding. The one on the right, we biopsied immediately, and the result was melanoma. Okay? Gums, two more lesions. Which one of these in your head would you be more concerned about? The one on the left or the one on the right? What do you think? Left? Right? All right, good. Yeah. So the one on the left is just toothbrush abrasion, very heavy, hard bristle, brushing hard for years, and actually just a little bit of sensitivity because of the exposed teeth. The one on the right, the patient had no symptoms except some necrosis and spontaneous bleeding. And you can see some of that white kind of necrotic stuff and spontaneous bleeding on brushing, but actually wasn't painful at all. So the one on the right, I was actually more concerned about and worried about. And on biopsy, that one was leukemic infiltration of the gingiva. Okay. And you can see on the left, there's nothing really to biopsy, right? You have some exostosis-like changes and some exposed teeth, but there's no lesion, there's no color change, there's no mass, there's nothing. On the one on the right, it's an abnormal gingival presentation, okay? The reason I didn't think right away that the lesion on the right was leukemia. That's not very common, but it can happen. It is a presentation. I thought it was maybe gingival hyperplasia, secondary to medications and things like that. But the patient was actually a young adult without any medications or any history of that. So that made us concerned and think that this is beyond just your typical gingivitis or plaque-induced gingival growth. Okay? So, next step, generation of a differential diagnosis. Right, so now we've looked at some lesions, we've appreciated what they look like, their color, their morphology, what looks better, what looks worse. The next step is to think about differential diagnosis. And the objective of differential diagnosis is exactly that, to come up with several diagnoses, not just one thing you think it is. And the mistake we make a lot of times in pathology, in clinically, and I used to do this before I was taught this kind of process, was we look at something and we try to diagnose it. As soon as we see a picture, we try to give it a name. And if we don't know the name, we're stuck. That's it. We don't know where to go from there. Okay? That's not how it works. The goal of differential diagnosis, and that should be your goal, differential diagnosis. Because if you have a very good, broad, and inclusive differential diagnosis, you're probably never going to be wrong as a clinician. When you get the biopsy or you get the follow-up and the final diagnosis, it'll probably be one of the things that you thought it was going to be. If you only say one thing, if it's not that, you're done. You're not so smart. Okay? So if you want to be smart, you come up with lots of possibilities so that you're never wrong. Right? The objective of a differential diagnosis is therefore to make sure that you include all of the relevant or possible or significant conditions so that you don't miss something important. This becomes very important because if you don't consider certain things in the differential, you may not take the next step and do what is necessary to make a more definitive diagnosis. So if you see a lesion and you think it's an infection, all you can do is wait and watch it or give antibiotics, for example, and et cetera, et cetera. If it doesn't heal or it doesn't go away or eventually it's something worse, that's it. You're done. You didn't help the patient whatsoever. But if you considered that maybe it's also something else and not just infection, like maybe it's a tumor or a cancer, then you would think, well, if it doesn't get better in a few weeks, maybe I should biopsy it. Because you considered in your differential that other possibility. And that will always lead you down a better path clinically and less chance to fail an accurate diagnosis. Right? The good thing about pathology is very simply, all of pathology, for the most part, 99% of it, can be broken down into three categories: developmental, reactive, or neoplastic. Okay? This really describes what we call the etiology of the lesion, or how the lesion comes about, or what causes it. Right? By developmental, we mean genetic things. They can be congenital, hereditary, acquired. With developmental conditions, there's generally some type of symmetry, or bilateralism, or a midline association. It's a very characteristic feature. Not in all cases, there's exceptions to every one of these, but the rule is important, because the majority of the time, the rule is what holds and applies, and you should at least know the rule before worrying about the few exceptions. Okay? Reactive conditions, what I mean by reactive is usually inflammation. The body reacts to something, okay? Things that end in itis, dermatitis, inflammation of the skin, conjunctivitis, inflammation of the eye, for example, of the conjunctiva, okay? This could be due to infection, trauma, autoimmune conditions, foreign body. Lots of things can lead to the body reacting to something, okay? But a lot of times you'll generally have characteristic signs and symptoms. Redness, heat, swelling, or pain. Not all of them, sometimes just one, sometimes just pain. Pain alone could tell you maybe this is an inflammatory process. Or redness, increased blood supply, vascularity, okay? Or swelling may tell you, without pain sometimes, may tell you this may be an inflammatory or reactive process, okay? And then finally, neoplastic. These are benign and malignant tumors. And for the most part, it's relatively easy to separate them clinically. Benign things tend to be well-defined. By definition, they're usually encapsulated or well-defined, orderly, not atypical. They don't spread, they don't metastasize, they don't kill you. That's why they're called benign. Whereas malignant things will change over time, will become more ill-defined or poorly defined, will be more infiltrative, will grow differently, may grow faster and more irregular or sporadic, okay? So these are features of benignancy versus malignancy, and they're very important clinically, because you can see those clinically and histologically, all right, so I have to give you a couple of slides on embryology, and the reason I have to go over embryology just a little bit and refresh everyone's memory, because I know everyone had basic embryology, is because without embryology, a little bit of knowledge predicated on embryology, you can't really understand developmental pathology. You have to know something about development and genes to be able to understand developmental pathology. So shortly after fertilization, we go through these 3 stages. You remember this? Morula, blastula, and gastrula, all right? 3 very important embryologic developmental stages, and important for understanding developmental pathology, all right? The most important stage here is really the gastrula. Why? Because this is when you form the 3 germ layers. You remember what those 3 germ layers are? Ectoderm, endoderm, and mesoderm. All of the tissues of the body will eventually arise from these 3 primary germ layers, all right? And you can see here, this is where the archenteron, or the primitive gut, forms. So this outside is what we call ectoderm, where I'm showing with the arrow, right? This area, this is the mouth, and this is the GI. This is what we call the endoderm. And everything in between is called the mesoderm, mesenchyme, right? Why is this important? Because, like I said, everything comes from these tissues. And when you start talking about developmental pathology, you can figure out where the germ layer or where the mutation occurred. It's actually very powerful. All right. So where do these germ layers lead to? Ectoderm, we know, is skin, hair, nails, enamel, right? And then specialized ectoderm, called neuroectoderm or neuroectomesenchyme, gives rise to head and neck and brain, nerves, and the rest of the tooth, besides the enamel, right? This is very unique to the head and neck structures, because other nerves are actually connective tissue and are mesoderm, right? So ectoderm, and then endoderm is digestive tract, which includes the liver and pancreas, because those are digestive organs, right? And then mesoderm, your connective tissue, which is bone, muscle, nerve, lymph, blood, and vessels, the spleen, splanchic mesoderm, all right? So think of ectoderm as everything that comes from the outside of those germ layers. Endoderm is the inside, the GI tract, and mesoderm is the mesenchyme, everything in between, all that connective tissue, okay? And then we get to morphogenesis. Within a few weeks, right, we start to see these structures form. The branchial arches, the frontonasal process, the maxillary and mandibular division of the first brachial arch, which then the frontonasal process will become your forehead and your nose. You can see the nostrils there. The maxillary and mandibular divisions of the first brachial arch will become the maxilla and the mandible. And so that's relevant to head and neck pathology or oral pathology, because abnormalities developmentally will come about because of problems during morphogenesis at some point during this development, genetically, genotypically, and phenotypically, okay? So the things we look for developmental pathology in the head and neck is anatomic variations, all right? Teeth are very important. Many syndromes that affect the body actually have head and neck involvement. Why? because the head and neck structures are some of the first structures to form before any of the other structures in the body. So if something goes wrong or a mutation goes wrong at that point during development, you can have something that's a syndrome that's systemic. We always look for head and neck findings. Okay? One of the most famous book on syndromes is by a dentist, an oral pathologist named Robert Gorlin, who passed away a few years ago. He was very smart. He was a dentist, and he was very good at identifying abnormalities in the head and neck because they're very common and eminent in syndromes. And that's why he was able to make a living being an eminent scholar in syndromes, and he was really just a dentist. But he identified these features. So what do we look for in teeth? Diffuse involvement of teeth. Several teeth involved throughout the mouth. Abnormal looking teeth. The color of the teeth may be different. The size may be different. The shape may be different. There may be pitting of the teeth. Okay? There may be too few teeth, hypodontia. There may be too many teeth, hyperdontia, or an abnormal amount of teeth, oligodontia. Okay? And then orofacial structures. Look at the head and neck. Is it dysmorphic? Is it malformed? But it's still relatively symmetric and bilateral. Is there a midline association with the abnormality that you're seeing? Are the facial proportions normal or abnormal? As dentists and aesthetic experts, we know perfectly facial proportions. We see a lot of faces. All we do is intraoral, extraoral exams. All we do is look at faces all day when we're in the clinic. Okay? So we know this anatomy better than any specialty, I would argue. Maybe ENT comes close, but that's it. And they don't go anywhere close in the mouth. They don't know what teeth or mouth even look like, for the most part. So here's a case. All right? Patient presents with disappearance of the teeth. Primary and permanent dentition were affected, very sensitive teeth. Two siblings, they also have this condition of primary and permanent teeth, and they have these weird-looking nails. All right? Do you think this is developmental, reactive, or neoplastic? Developmental, right? Siblings affected, young age, primary and permanent teeth. Okay, everything about this says developmental, developmental, developmental. As long as you know that, that's very powerful. Why? Because if you don't remember the name of this condition, you can just go to Google and type in developmental oral pathology with abnormal teeth or missing enamel, because that's what it looks like. It looks like the dentin's there, but the enamel's gone, right? And you can actually type in abnormal nails, and that'll give you your differential diagnosis. But you don't know what to type in Google if you have no idea where you're even at. If you put cancer for this and you type in Google oral cancer, that's not going to give you the correct differential diagnosis. Okay? If you put in reactive or inflammatory condition of the oral cavity, that's not going to give you your right differentials. You have to know what category you're in, developmental, reactive, or neoplastic. That's enough to get you to your right differentials just by using the internet. Okay? What do you guys think? Any differentials for this? What? Amelogenesis imperfecta? No. Dentidogenesis imperfecta? Odontogenesis? Okay. What else? What enamel comes from what germ layer? Ectoderm. Nails and skin and hair come from what germ layer? Ectoderm. This is a case of ectodermal dysplasia. Do you see why knowing the germ layer is of critical importance and why you need to know a little bit of embryology? Because if I look at this and go, look, two ectodermal structures are abnormal and altered, my first guess is going to be ectodermal dysplasia. What's that? Hair? Hypodontia? Can and don't have to. Yeah. What's that? Hypotrichosis? This patient didn't. I had two excellent questions. Hypodontia and hypotrichosis. Okay, because there's a and anhydrotic, hydrotic, ectodermal dysplasia. This is the interesting thing. With most conditions, whether it's developmental, reactive, or neoplastic, here's a pearl. No two patients are the same, and no patient has the complete expression of what you see in the textbook. No, not that either. Yeah. And the reason for that is everything ultimately is genetic. Tumors, cancers, inflammatory things, immunomodulated genes, and everything like that. And it depends on how much expression of the genes and penetrance of the genes and lots of other genetic factors determine the phenotype. Therefore, You could have 1,000 cases of ectodermal dysplasia. No two are going to look the same, and not every single one is going to have sparse hair, abnormal skin, abnormal nails, abnormal teeth. Some only have the abnormal teeth. That's all their expression is. So you have to still know, look, enamel is missing, abnormal teeth, enamel is ectodermal. Therefore, if it was just this teeth, you should be able to think ectodermal dysplasia is a plausible differential diagnosis, even without anything else. And that's true for everything. This could have been amelogenesis imperfecta if it didn't have the nails and the hair and things like that. So just keep that in mind, that no, there's always a spectrum of presentation for anything. And so what I'm trying to teach you is actually not to memorize that one picture of, the abnormal skin, hair, nails, and teeth, and say, that has to be ectodermal dysplasia. Even a subtle change, as in just bilaterally having teeth missing enamel, ectodermal dysplasia could be that expression, genotypically and phenotypically. And to be more definitively diagnostic, what would we do for this patient? I'm not thinking it's inflammation, so I'm not going to give them anti-inflammatories or antibiotics. I don't think it's tumor. I'm not going to biopsy anything. I think this is genetic and developmental, so I'm going to send them to see a physician or a geneticist for gene testing, for more definitive diagnosis with genetic testing, and for counseling, because there's a chance to pass this trait on if these individuals have children. So knowing which category, developmental, reactive, or neoplastic, is profound for differential diagnosis, and knowing where the patient goes next or what to do next to get a more definitive diagnosis. Okay? How about these? The one on the left, give me at least a couple of differential diagnoses. Amelogenesis imperfecta, good. A developmental condition, bilateral, diffuse, all the teeth are affected, amelogenesis imperfecta. Could it be ectodermal dysplasia? Why not? You're missing enamel, that's an ectodermal structure. If I told you that that patient also had sparse hair, abnormal skin, nails that were abnormal, then you'd say, oh yeah, the ectodermal dysplasia. What are the chances they have amelogenesis and ectodermal, right? Okay, right. But it is amelogenesis imperfecta, good. How about the one on the right? Dentinogenesis imperfecta. And when we see dentinogenesis imperfecta, we actually, for either of these, gene testing again, and for dentinogenesis imperfecta, some subtypes are associated with osteogenesis imperfecta. And that's very important to know at a very young age, to be able to prevent some of the skeletal fractures and complications that could be associated with that. So when you see dentinogenesis imperfecta, there's another step that you need to go to. Okay? So we all know what normal facial proportions are and aesthetics and things like that, so I won't belabor that. But here's a little kid, and the parents didn't actually know that anything was wrong until an astute clinician kind of said, okay, I think something's going on here. Why? What's abnormal? It's a very big head, very sparse hair, very low set ears, right? No hair on the eyebrows, right? Just very small mouth, very small teeth, micrognathia we call it, microstomia, microdontia, very small teeth. Very characteristic head and neck features. Here's a profile. Okay? Profile makes it a lot easier, right? So developmental, reactive, or neoplastic. Developmental, right? Everything about this should tell you that there's something genetic, abnormality, hereditary, or acquired that happened early on that resulted in this developmentally abnormal phenotype. Okay? This is something called Hallermann-Streiff syndrome, and who cares what the name of this is? You'll never see it. I'll probably never see one again. I've only seen one. The point isn't to memorize Hallermann-Streiff syndrome. The point is to know that this is characteristic of a developmental condition and that that patient needs that type of workup and evaluation. Okay? How about this? No symptoms, no pain, no problems. Developmental, reactive, or neoplastic. Developmental. This is maxillary hypoplasia. Okay? The maxilla is very small because it didn't develop normally. So genetically and phenotypically, there's a developmental abnormality. If you just go into Google and type developmental oral pathology with small upper jaw or hypoplastic maxilla or whatever, you will get this diagnosis. It'll be one of the first 5 to 10 that come up. Cruzon syndrome. Who cares? It doesn't matter what this name is. We're going to forget this tomorrow. Okay? If you don't, good for you. But I don't even care to remember this tomorrow. The point is I can see this case and know, aha, developmental, developmental, developmental. And now I know what to do. Now I know how to get to the right diagnosis. Okay? There is a process. There is an art to diagnosis. It's not memorizing the picture and giving it a name because you know it and you've seen that picture and you had an exam on it in one class. It doesn't work that way. Okay? How about this one? Do these facial proportions look normal? This girl has a very characteristic gaze. She's looking upward to the heavens. And we call this phenotype and problem cherubism. Okay? It's a developmental genetic mutation abnormality, starts at a young age, and they get these giant cell tumors in the bone that then expand and cause enlargement, and they get this characteristic facies, which is a very large kind of moon-like facies appearance. Okay? Developmental, developmental, developmental. Okay? If you put in Google, developmental condition with a baby with a fat face, you'll get cherubism. It'll come up. Okay? All right. How about this one? What do you think is the etiology of this? Developmental, reactive, or neoplastic? Reactive. Good. This was actually very painful. It hurt the patient when they would bite down or eat foods, hot, cold, etc., etc. It only been there for like 4 or 5 weeks that the patient could remember. Okay? It's only on this side. So developmental, reactive, or neoplastic. Probably developmental. Maybe neoplastic. Still, pain, few weeks, duration. Doesn't really fit with tumor or cancer. But it is kind of like a leukoplakia, but you can see some striae almost, like these little white areas that come off. And there's an area of ulceration. So my best guess would be reactive also, right? And what's the normal anatomy that's affected here? Mucosa, right? So we call this mucositis, right? Because itis is inflammation and reactive, and this is mucosa is the normal anatomy at the site. Okay? Now, the key is when you have a mucositis clinically, what's causing it? Is it mucositis from drug reaction or fillings? Is it a true autoimmune like lichen planus? At that point, you may need a biopsy, or you may just want to give the patient some topical steroid, change some metal fillings to non-metal, and see if it resolves in a few weeks or months. If not, then you can worry and take a biopsy, for example, to make a more definitive diagnosis. Right? And this was a lichenoid mucositis. This was they had the metal restorations and drug medications that could both have resulted in this. And we were able to resolve it, actually, through restorative care and changing those medications. Okay? Very painful gums, 1 week duration. Bleed spontaneously, extremely smelly and painful. Developmental, reactive, or neoplastic? Okay? What do you think? Developmental, 1 week duration in an adult, that'd be weird. A couple of weeks, doesn't really fit. Although it is diffuse and all over the place, doesn't really fit with the developmental condition. There's redness, swelling, pain, characteristic signs of inflammation here. Okay? So your best guess really should be reactive. Okay? Now, maybe this could be a leukemia, maybe it's neoplastic, but you can always figure that out after the next step. But definitely developmental wouldn't be good in this category. Interestingly, neoplasms like leukemia, when it involves the gums, doesn't really hurt much. That's not a characteristic feature of 1 week onset and painful. Okay? And this was actually ANUG, acute necrotizing ulcerative gingivitis. Okay? Blisters, about 5 days duration. Patient felt some tingling. Then these came up on the lip. Very painful. Developmental, reactive, or neoplastic? Reactive, inflammatory. Good. This is what we call recurrent herpetic dermatitis. It's skin inflammation, dermatitis, due to herpes. In dentistry, we call it recurrent herpes labialis. Okay? Labialis doesn't mean anything. Dermatitis means something. It tells you what's going on. It's a virally induced inflammation of the skin. Okay? Right? Developmental, reactive, or neoplastic. Sometimes you need more information, right? Sometimes you need to know, How long has it been there? And you can ask these things clinically, but I want to show you that just by looking at it, you could get a really good differential without knowing anything more. Just by the color, the shape, location, and using this understanding of developmental reactive and neoplastic, okay? So this patient, after I asked them, has had this their whole life. And it's gotten a little bigger over time. Doesn't hurt at all. Doesn't bother them. But they want to know what it is as an adult and want to get rid of it if they can, and they're concerned about it, okay? Developmental, reactive, or neoplastic? I heard developmental. Anyone for neoplastic? Neoplastic? Okay. You're both right. Right. So this is actually a hemangioma. And there's still debate as to whether a hemangioma is a developmental lesion or a true tumor, because it's called oma, hemangioma, right? It's 50-50. You ask some pathologists or clinicians whether it's developmental, they'll say, yes, of course, it's developmental. Many of these regress when you get older, they go away, it's a developmental genetic thing. And other people will tell you, no, these are true tumors. I really don't care. Once you could even get to the point where you're saying it could either be developmental and neoplastic, you're way ahead of the game. So good job. Right. Developmental, reactive, or neoplastic. 3 months duration, no pain, no symptoms, doesn't bother the patient whatsoever. Developmental? No. Reactive? No. Neoplastic? Yes. Benign or malignant? Why? Okay, why benign? Why malignant? It's not very well circumscribed. There are rolled borders. It's infiltrating. It's endophytic. It's going in. There's no more epithelium. It's missing. This is ugly. It may not be very big and very ugly, but it's ugly. And you should at least be able to identify that this doesn't look like a well-defined, round, encapsulated, benign lesion. This is actually an infiltrative, ugly lesion. We biopsied this, and it was squamous cell cancer. Okay? 2 months duration, this growth started coming out and displaced the denture in an older patient. Okay? It doesn't hurt them. They have some tingling and numbness in the area. No pain. Okay? Developmental, 60-year-old female, male. Developmental, reactive, or neoplastic? Okay, I heard reactive and I heard neoplastic. Okay? If it's reactive, this size, no pain, you know, that's weird. I'm just saying, you know, that's a little weird. Neoplastic, yes, neoplasms, cancer doesn't hurt. If it did, everyone would be presenting to us early with stage 1 cancer. Pain is usually, for most cancers, an advanced feature, okay? Advanced stage feature. So this was worrisome, and I biopsied this right away. And I didn't expect this, but it was a metastatic cancer from the kidney, renal cell carcinoma. That wouldn't have been my guess. And who cares? That's not the point. The point is to know this isn't reactive. You can't just give antibiotics. Or if you do and it doesn't go away in a couple of weeks and it gets bigger, you do a biopsy because it could be neoplastic. Okay. And I live in LA. We have LA County Hospital. We see a lot of gang violence and things like that. So we see some crazy stuff. Developmental, reactive, or neoplastic here. This patient came to the emergency room at 3 in the morning to LA County Hospital with this presentation. Developmental, reactive, or neoplastic? Reactive. Why? What are the signs and symptoms of inflammation? What are the cardinal signs? Redness, heat, swelling, pain. I don't know if this is hot or not, but this is red. It's bleeding. It's swollen. It's painful. He's presenting to the emergency room with this. Reactive, reactive, reactive. Okay? If now this had, you know, this is reactive here. So this is actually a gunshot wound to the face. This is the entry wound right here. And the exit wound was the eye. And this individual had to have exoneration of the eye, so they lost their eye and associated structures and things like that. Sorry, I know it's horrific, but I want to really drive the point home that you understand very clearly developmental, reactive, and neoplastic. Because this is what you're going to do every time you see a case from now on. You're going to look at it, you're going to identify the abnormality, you're going to ask the patient questions, you're going to touch it, you're going to feel it, you're going to look at the color, and you're going to think first developmental, reactive, or neoplastic, and then make your differential diagnosis from that. Okay? So, normal anatomy is what really gives you the final differential diagnosis. So, all right. So, here's a mass or a growth. Right? It's in the parotid region. Now, the normal anatomy at the site is what gives you your differentials. This on biopsy happened to be a salivary gland tumor or malignancy. But the art of differential diagnosis is not just doing a biopsy and getting the answer, knowing lots of different things that it could be so that you're not wrong. Okay? And if you had to tell me other things this could be besides a parotid tumor, right, what would some of your differential diagnosis be? When I look at this, the way I approach these cases is I think, what's the normal anatomy at the site that's altered or abnormal? I know this doesn't look normal on this patient's side. I look at the skin, and the skin looks normal. So I don't think the skin is the problem here. I think whatever's under the skin is what's pushing out and causing this pathology. What's normally under the skin there? There's fibrous connective tissue. So why can't this be a big fibroma or a malignant fibrosarcoma? Okay? There's muscle there. Why can't this be a rhabdomyoma or a rhabdomyosarcoma? There's nerves there. Why can't this be a schwannoma or a neurosarcoma, for example? All right? There's blood vessels there. Why can't this be a hemangioma or an angiosarcoma? Right? That's the art of differential diagnosis. If I told you this was bony hard, then what would some of your differentials be? Osteoma or osteosarcoma, because it could be coming from the jawbone. Right? That's the art of differential diagnosis, considering all the possibilities. This doesn't look vascular, so I wouldn't think hemangioma, and it doesn't feel bony hard, so I wouldn't think bone. But everything else is fair game. Okay? How about this? What's the normal anatomy here? Mucosa, connective tissue, right? What's abnormal here? Is the mucosa abnormal? It's still smooth, kink, it's just stretched a little. Where is the abnormality? Where is it anatomically? Below the mucosa, right? What's normally there anatomically? In that location specifically? Fibrous connective tissue, right? There are minor salivary glands. There could be muscle. So what would your differentials for this lesion be? There's fat. So your differentials could be fibroma, lipoma, rhabdomyoma, schwannoma, etc., etc., etc. That is the art of differential diagnosis. This was a fibroma on biopsy. All right? We have a white plaque. What's the abnormality? Is it the mucosa or is it underneath the mucosa? It's the mucosa, right? It's the surface that's altered. It's the surface that's white. So all of your differentials for this lesion should be coming from surface anatomy. So you should either say this is keratosis or leukoplakia or precancer or dysplasia, etc., etc. Because it's coming from the surface. All of your you shouldn't say fibroma. You shouldn't say lipoma. There should be no differentials from the connective tissue. Okay? This was actually a leukoplakia clinically, dysplasia on biopsy. Okay? What's the normal anatomy here? We have mucosa, then we have connective tissue, and then we have bone. This is the alveolar ridge of the mandible, right? What is abnormal here? Mucosa, right? The mucosa is ulcerated, it's ugly, it has rolled borders, it looks like it's going in, right? So all of your differentials should come from the mucosa. Do you think this is developmental, reactive, or neoplastic? Neoplastic. Benign or malignant? Malignant. So mucosal malignancy. What's the name of this? Oral squamous cell carcinoma. Or mucosal cancer. Same thing. Okay? This is a patient that presented with swelling and pain in this region of the palate. You can see that swelling. And so what's the normal anatomy here? You have mucosa, then you have connective tissue, and then you have bone, and then you have sinus, right? What looks abnormal here? Is the mucosa the main problem? Is it something underneath? Could be mucosa. There is some red change there. But there's a lot of expansion too. So maybe something underneath because it's pretty broad. So this is tricky. What if there's something from the sinus pushing down here? This is a very hard one. Okay? So we scheduled this patient for biopsy, gave them NSAIDs and antibiotics. A week later, they came back for the biopsy, and this is what it looked like after we'd given them a week of antibiotics and NSAIDs. There was no more swelling, but there was a piece of bone showing in the jaw. Right? So we removed that bone, and microscopically, it was basically just osteomyelitis. This patient was on medications called bisphosphonate medications, and this is this condition we call osteonecrosis of the jaw, associated with medications like bisphosphonates or anti-resorptive medications. Patients take these medications for cancer or for osteoporosis. And this is something that we're starting to see more regularly, and it's a relatively new condition. All right, so that's the art of differential diagnosis. Identify the abnormality, know what's there, and then figure out whether it's developmental, reactive, and neoplastic, and then your differentials come from that. So you can always do a definitive diagnostic procedure, right? There are procedures that are non-invasive and invasive. Non-invasive procedures like diascopy. Diascopy is just a fancy term for blanching a lesion that looks vascular, and if it gets pale or it blanches, then you know that it's vascular. Usually you don't need to do that. You can look at it and tell that it's vascular, right? Staining, culture, cytology. But the invasive procedures are still the gold standard for diagnosis of lesions when you don't know what it is, for the most part. Okay? And biopsy, surgical biopsy, is really still the gold standard. To get some intact representative sample of tissue and get it to the pathologist to make a more definitive diagnosis. Okay? So for surgical biopsy, you obviously want a representative sample. I'll just show you an example here. This was a 21-year-old male with a white lesion, kind of a red-white lesion of the tongue, dorsal and some areas that went to the lateral tongue. Didn't know what it was, wanted to know what it was, wasn't painful, so it was, I had differentials, but I wasn't sure if this was reactive or neoplastic. It'd been there for a few months, and I just couldn't tell. So we did a biopsy, and the diagnosis, and biopsies are easier, just get it to your surgeon. Whenever you have a lesion and it's been more than a few weeks or a month or two and you don't know what it is, just get it to a surgeon that can do a biopsy. And in that case, the diagnosis was actually lichen planus, histologically. So not a typical presentation for lichen planus, but at least now we had a definitive diagnosis, and we treated it with topical steroids, and within a few weeks it went away. And at least we knew it wasn't precancerous or it wasn't erythroleukoplakia, even though it was kind of reddish and white. And so that's the value of biopsy. Here's a patient that presented with a rubbery, well-defined submucosal mass in the upper lip. Okay? So for a lesion like this, just to give you an example, that when we do surgery, we're also using the same principles of understanding the anatomy and where the lesion comes from. All right? And in a case like this, what would be some of your differential diagnosis? Do you think this is 3 months duration, feels rubbery firm, not painful at all, but patient wants to get rid of it, doesn't know what it is, and we're not exactly sure what it is, so we want to remove this and biopsy it. Okay? Is this something that we would do an incisional or an excisional biopsy? Some would say, I'll do an incisional first, get a result. If you're a surgeon, this is small. You could remove this relatively easily in most cases. So where is this abnormality coming from? Is it the mucosa that's affected? Or is it from underneath the mucosa? Underneath, the connective tissue. So do you think it's developmental, reactive, or neoplastic? Neoplastic. Benign or malignant? Probably benign. I mean, it feels very well defined, but that's why we biopsy, right? That's how we know more definitively whether some things are benign versus malignant. So same thing. We thought that this was probably kind of a benign growth or tumor. It felt pretty firm and well defined. But because the mucosa is normal, I don't need to send the mucosa to the pathologist. The pathologist doesn't need doesn't need to see the mucosa on this. Okay, I can just do an incision and blunt dissect this lesion out. And when you blunt dissect this lesion out, you start to see exactly what it looks like. It looks very yellowish, but very well defined with a glistening, smooth capsule around it. Okay? with some nice blood supply. Tumors need blood supply. And this was easily removed in toto, and the diagnosis was pleomorphic adenoma, a benign, encapsulated, well-defined salivary gland tumor, which is probably one of the things we would have thought it was in our differential. Okay? You have minor salivary glands in most places under the mucosa in the mouth. Probably the gingiva is one of the few places you don't. Otherwise, most locations, you can find a salivary gland here or there. All right. Treatment. Treatment's easy. I don't have many slides on treatment because it's all about diagnosis. Why? If you have a right diagnosis or get the right diagnosis or the right differentials, you can go reference the treatment. And treatment changes weekly and monthly and yearly and all that. So I don't need to talk about the treatment in every single one of these lesions that I showed you today. You can just go and put in what you think your differential or diagnosis is, and you can get state-of-the-art, up-to-date information on treatment, standard of care, or the different treatment modalities for that diagnosis. So the key is the diagnosis. If you don't have the right diagnosis, it's all bad from there on, okay? Because you may not do the right treatment or do a biopsy when it may be needed, okay? Or do one when it's not needed, and you won't get to the right answer necessarily, and therefore you won't be doing the right treatment, okay? So there is really a flow and a process here. And so really treatment is really reference material. And then clinical follow-up. Clinical follow-up is actually very important. Why? Because a lot of these lesions I showed you, some of them you don't have to biopsy. You can watch for a few weeks, see if it resolves, have the patient avoid touching it, put some topical steroids, see if the ulcer heals, for example. But you do have to have some follow-up for a lot of these things, because how do you know if it's going to heal or not if you don't follow up? And whether you need to do a biopsy eventually. So follow-up clinically is very important for most pathology. It's not a one-time thing and you're done. You got to see the patient back, make sure what you did took care of the problem and that it went away, or if it didn't, then do a biopsy or refer them for a biopsy. Value of follow-up is that recurrence varies for different diagnoses, so even if you remove it, there's a chance it can recur. So you need to follow up the patient for some amount of time at least to make sure it doesn't recur, because the sooner you catch it, the easier to treat it again. Many oral lesions, by their nature, are chronic processes, so you really have to follow them up in order to manage them. It also helps you avoid missing a diagnosis that's more important, because you think it's something, you might be wrong. No one's ever always right. And therefore, follow-up will let you fix that and catch it at an appropriate time. In the United States, we have significant medical legal implications if we don't follow up or if we fail to diagnose. A lot of the malpractice cases that I've been involved with in the realm of medicine and dentistry are negligence or failure to diagnose. You know, the clinician had been watching this thing for years, and eventually someone biopsied it and it was cancer. And that clinician that was following it for years is below standard of care now, because there's no reason they shouldn't have at least referred it for evaluation or a second opinion or biopsy. Okay? So, you know, in the US, we have a lot of medical legal implications. And also rapid treatment intervention. Good follow-up lets you intervene quickly and manage it more effectively. Okay? So remember that differential diagnosis is the key, and the objective is that your differential diagnosis should include all the potential lesions so that you don't miss something important. And ultimately, this is for the sake of your patients and their well-being. You don't have to get the right diagnosis. You don't have to look at something and know exactly what it is. Okay? You just have to be able to be at least as broad as developmental, reactive, or neoplastic, and then use your normal anatomy and histology and that expertise and understanding to then generate differential diagnoses. Okay? So if someone comes up to you and goes, I have this red rash on my skin. It's been there for about a week, and it's very itchy and it hurts me. What's your diagnosis? What's the normal anatomy of the skin? Skin, derm. And this is probably itis, dermatitis. All right? So what do? It doesn't have to be mouth. This is anywhere in the body. Even radiologic diagnosis, this type of paradigm applies, right? You have a dermatitis. Okay, let's rub some steroids on it or wait a did you touch something? Or do you have allergies? Let's give it some time. Hopefully it'll go away, right? If it doesn't go away with topical steroids and treating the inflammation and giving it time, then you can worry and say, well, maybe it's something else. Maybe you should go see a dermatologist or a specialist. Maybe they need to do a punch biopsy, et cetera, et cetera. Okay. All right. Thank you very much, and I'll take any questions.
Thank you, Dr. Barish, for this nice and interesting presentation. Now for male side, any question or comment?
All right.
No question. Female side, any question or comment? No comment. Thank you, Doctor. Thank you for your listening and attention. Thank you so much.